Hi everyone, I apologize for not being there live and in color today, but life throws you curveballs sometimes, and this time mine was in the form of an ethics presentation I must give today. That said, my absence is not reflective of the priority of your learning. I care deeply about your comfort of the material, so please feel free to shoot me an email and we can set up a time to meet if need be for clarification on this material or any other material in this course. Okay, so let's get started. First of all, I want to thank Paul for entrusting me with this content and for the countless ways he has shown excellence in mentorship. Today, we will be discussing hip disorders, and I have attempted to chunk the information into categories starting with soft tissue pathology, then progressing to bony pathology. I have further broken that down into symptom location, including anterior, posterior, and lateral, as well as the difference between intra-articular and extra-articular pain sources. So here are the objectives for this talk. As in the lumbar spine, when we start with a patient, we want to rule out any systemic red flags, such as trauma, fever, weight loss, painful urination, night pain, prolonged corticosteroid use, and/or cancer. We also want to rule out any more local red flags of serious hip pathology that justifies referral, including avascular necrosis, or AVN, and fracture. Briefly, AVN is a degenerative bone condition characterized by death of cellular components of bone due to its disrupted blood supply. Full range of motion will rule this pathology out. Initially, these individuals will have pain with weight bearing. However, as the condition progresses, they may complain of pain at rest. It is seen mostly in 20 to 40-year-olds. It can also occur with either traumatic or atraumatic mechanisms. Risk factors include excessive alcohol use, steroids, smoking, high BMI, and a history of fracture or dislocation. We will go over fractures in more depth during the bony pathology portion of this lecture. Tests such as the patella pubic percussion test and fulcrum test are very gross ways to attempt to identify a fracture. When suspicions are high, you must refer for further diagnostic testing. Before we hone in on the hip, we want to screen other areas for pain referral as well as impairments. A loose rule for you to follow is that our attention should turn to the hip in patients presenting with a limp, morning stiffness, and only groin pain with limited internal rotation. Also, a quick note on imaging. I know David goes through this in more detail, but please remember that morphology does not equal pathology. There is no evidence for added benefit, both diagnostically and prognostically, if your clinical exam can classify your patient. Imaging at times can be problematic, as 90% of asymptomatic individuals with impingement have abnormal findings, as well as 70% of abnormal individuals having labral tears. So finally, honing in on the hip, when discussing common hip disorders, we are going to classify or group them as you see here based on location, as well as intra or extra-articular. We will start with groin pain, which can be very difficult to differentially diagnose. Our extra-articular hypotheses can include acute muscle strains, overuse injuries to the adductors and psoas, as well as apophysitis in our younger patients. Our intra-articular hypotheses can include FAI, or femoral acetabular impingement, labral pathology, and osteoarthritis. With extra-articular sources of pain, patients are usually able to put their finger on the pain, versus intra-articular, the pain is going to be more deep and difficult to localize. When we look into our subjective data for our patients with groin pain, we see a higher presentation in males than females, excluding stress fractures. In younger skeletally immature patients, we must consider the apophyses or avulsion fractures. The pelvis is the last bone to mature, so the risk of apophyseal pathology can occur until our early 20s. And finally, with an acute mechanism, we must suspect pathology in the musculotendinous junction, while more chronic or overuse injuries, we're going to suspect more bony stress reactions or tendons. You will see some obvious mechanisms associated with muscle actions listed here. More specifically, when we see a patient who reports anterior groin pain while extending the hip from flexion, we can suspect internal snapping hip syndrome. When we see these specific demographics or patients reporting the following, we can suspect an adductor strain. And when we see a patient with severe lower abdominal pain, pubic pain, or groin pain with exertion, which is relieved by rest, we suspect athletic pubalgia or sports hernia. And finally, when we see this demographic or hear these complaints, we suspect osteitis pubis. So now that you have a working hypothesis based on what your patient is saying, your objective exam will focus on confirming that through palpation and other special tests, including resistive tests. This table attempts to organize objective tests into clusters to classify a patient as having a particular pathology. We will discuss these tests in the hip exam lab, and you may refer back to this table then. Now that you know what may be going on, let's get into details of etiology to better inform our treatments. Risk factors for adductor strains include adductor weakness, abductor-adductor muscle imbalance, or a decreased hip range of motion. Thus, it would benefit our patients to measure and address these. Please remember the importance of the lower abdominals in stabilizing the pelvis. If the abdominals fail to do this job, it sets up the adductors for excessive demand and strain. Treatment of the adductor strain includes anti-inflammatory routines in the beginning, along with isometrics. That progresses to more flexibility and core strengthening, and then finally focuses on restoring proper biomechanics and building muscle and tendon resiliency through an eccentric program. Surgery is reserved for more severe tears. We also want to consider our role in prevention of injury through appropriate strength and range of motion. The protocol on this slide is for your reference only. The main takeaway is that patients who were randomized to active PT, including isometric adductor activation, progressing to adductor strength, as well as abdominal strength, improved substantially better than the passive group. Moving to athletic pubalgia, also known as sports hernia or Gilmer's groin. A typical etiology is weakness of the posterior inguinal wall without a clinically palpable hernia. Mechanisms include an insidious onset due to repetitive twisting of the thigh and trunk, as well as muscle imbalances of the abdominals and adductors. There is a lack of consensus of what is exactly torn, either one or a combination of the transversalis fascia, distal rectus abdominis, conjoined tendon, and or external oblique. Traumatic mechanisms also occur and include extension of the trunk with thigh abduction, creating injury at the insertion of the abdominals on the pubic bone. Specifically, Gilmore's groin is defined as tears in the external oblique aponeurosis and conjoined tendon. Unfortunately, we do not have strong evidence to guide our management of these patients. This table is for your future reference. Big picture takeaway is that as symptoms improve, we begin to progressively strengthen and improve motor performance of the core and hip muscles, turning attention to neutral spine and no Trendelenburg with activities. This is a protocol from a case series that can be used for reference when managing patients with this diagnosis. This group returned to play after 12 weeks of manual therapy to the hip and progressive exercise. This is also a reference slide for classifying severity and helping decision-making with these patients. And finally, if a patient is to receive surgery and you are assisting with post-op rehabilitation, you may refer back to this slide for inspiration. Next, we will discuss osteitis pubis. Osteitis pubis is well recognized in postpartum patients. Stress to the pubic bone creates inflammation of the bones, symphysis, and adjacent structures. We may also see periosteal trauma and erosion of the symphysis in more severe cases. It can be seen in isolation or with other conditions. It is most commonly seen in athletes pregnant females, or after pelvic trauma or surgery, and there has been correlations made with a limitation in hip internal rotation. Regarding physical therapy management, we can use this case series for reference. The takeaway from this slide is that we need to consider these 9 elements in a progressive management of our patients with osteitis pubis, including lumbopelvic stability, motor pattern training, pragmatic manual therapies, followed by general strength and conditioning of the lower quarter. This slide shows how this group progressed their patients through rehab successfully and can be used as a reference slide. They started with transverse abdominis and oblique activation, as well as hip abductor strengthening, progressing to adductor strengthening, then functional movement retraining, and finally functional strength. If conservative management fails, we may look to cortisone injections and surgery, which has an 80% success rate in chronic cases. Another relatively common diagnosis is iliopsoas tendinitis and internal snapping hip syndrome. Typically, we see more of a tendinosis due to overuse, repetitive movements, and faulty mechanics. Internal snapping hip may or may not be painful, and we see this more in ballet dancers and runners. Just to provide anatomical reference, we can see the potential of the iliopsoas tendon and the IT band snapping over bony prominences as the leg moves from flexion to extension. Treatment includes an anti-inflammatory routine if in the acute phase. Physical therapy includes a pragmatic approach of manual therapy and exercise. Failure of this conservative management includes injections and surgical release. I wanted to stress the importance of why. We cannot just provide a diagnosis and acute management of a patient's symptoms. We need to discover why the pathology occurred and manage those reasons or impairments accordingly. We will now move from extra-articular groin pain to intra-articular groin pain. We will start with stress fractures by dividing them into 2 categories, fatigue and insufficiency. Fractures typically occur in the femoral neck, pubic rami, acetabulum, femoral head, and sacrum. Most common is the femoral neck, where we see fractures either on the tension side, which are unstable, or the compression side, which are more stable. Patients with stress fractures will complain of exercise-induced pain. Risk factors for stress fractures are listed here. Recall from prior imaging lectures, plain radiographs are only 10% sensitive, thus MRIs or bone scans are required. Unfortunately, due to vague symptoms and limited imaging findings, the median time to diagnosis is about 30 days. Treatment of unstable tension side fractures includes pinning, while the compression side treatment is 6 to 8 weeks of limited weight bearing. As healing stabilizes, physical therapy is tasked to address biomechanical factors as well as education on risk factors. Moving on to one of the most prevalent, FAI, or femoral acetabular impingement. FAI occurs with either an abnormal acetabulum, abnormal femur, or both, which can be congenital or due to increased repetitive stress. Unfortunately, this is associated with an increased incidence of early osteoarthritis. There are 2 types, pincer, which is an abnormal acetabulum seen mostly in females, and cam, which is a femoral abnormality occurring mostly in males. 86% of the cases, however, are mixed. Please remember that the prevalence of cam in asymptomatic individuals ranges from 37 to 67%. Moving on to a more detailed description, a pincer type is defined by acetabular overcoverage. On x-rays, we will see possibly acetabular retroversion, where the socket is facing more posterior than normal. A consequence of this can be posterior inferior cartilage abrasion. The cam type is seen as femoral abnormality, including a loss of normal concavity of the femoral neck. This can be due to growth abnormalities or a history of skiffy or leg calf-perthy disease. In this case, the femoral head jams into the acetabulum, creating shear forces and diffuse articular cartilage damage. Radiographically, we see femoral retrotorsion. A recent NFL Combine study found a cam deformity of more than 65 degrees in 90% of asymptomatic players. We see this pathology present in mostly younger patients with hip pain, a reduced range of motion into hip flexion and hip internal rotation, and a history of repetitive microtrauma. Patients may express difficulty squatting or with lateral and cutting movements. At times, we can see lateral or posterior pain with external rotation, stair climbing, or prolonged sitting. During your exam, you may find sharp groin pain and or severe range limitations with hip flexion and internal rotation. We will also get positive impingement tests that you will learn in an upcoming lab, including Fader and Faber. Conservative management should always be considered before surgery. This slide demonstrates a great manual and home therapeutic program for patients with FAI, which we will discuss in our exercise lab. This slide offers suggestions for treatment, assuring that we are addressing motor performance into all directions of the hip, as well as the trunk, and then progressing into function. Manual therapy selection in this protocol is based on pragmatic findings. We do see success with surgery, but it is not always necessary. The aim is to improve clearance for the hip to improve range of motion. Most surgeries are now done arthroscopically and have high rates of satisfaction and return to activity. That being said, patients tend to do better with surgery if there is no presence of OA. However, experts are questioning the cost effectiveness and long-term outcomes of these procedures. The preference is to trial at least 6 months of conservative management, then consult for surgery. If surgery is performed, the next handful of slides will provide as a reference. This protocol is based on best evidence, however, has not been empirically tested yet. You will not be tested on these slides, but use the photos to inspire ideas for lab and future patient care. In phase 1, we see activation of muscles in a non-weight bearing progressing to a full weight bearing position. We then see progression of stability and more functional postures, including single leg tasks that become more dynamic. We then prioritize complex dynamic activities, including plyometrics and running. A final note on surgery. We must question the repair of the capsule. If the capsule was closed, we must protect excessive hip flexion and extension past neutral and gradually add hip mobilizations. If the capsule was left open, mobilizations are contraindicated. This slide provides another reference for post-op arthroscopy protocol. Next, we will discuss labral tears. Important to note is a positive test found on imaging occurs in 70% of asymptomatic people. Labral tears can be degenerative or traumatic. Degenerative tears occur after years of repetitive minor injuries and are usually associated with arthritis of the hip. Traumatic injuries can occur with rapid hip motion or sudden stops and turns. This schematic is a great representation of the cycle of joint dysfunction and compensatory movement strategies that thus create more joint dysfunction. We will discuss a positive finding for labral pathology in lab, but it is important to remember that a finding of pain and a reproducible click has a positive likelihood ratio of 7 for a labral tear. Over the last decade, the discussion of and resources put towards diagnosing and managing labral tears has increased, but it is still not a perfect science. It is suspected that arthritis is preceded by labral pathology in up to 60% of those undergoing a total hip arthroscopy. Patients with labral tears complain of groin pain with or without clicking, while clicking increases the likelihood ratio to 7. Risk factors include prior hip pathology, FAI, and repetitive pivoting or hip flexion. Patients may present with a Trendelenburg or a limp and often test positive for impingement. The gold standard diagnosis in which to guide surgical decisions is relief with an intra-articular injection. This is a test we will learn in lab, but wanted to present the psychometrics here for you to see. With this test, we are looking for pain and a reproducible click. Though we will learn many tests for the hip, they are not perfect. Regarding the labrum, our tests are sensitive, meaning a negative finding can rule it out. However, most tests have very low specificity, leaving us wondering still when tests are positive. Returning to our gold standard, the reference is an MRI with an injection of a dye. As you can see, plain MRIs are not enough, neither are radiographs. So how do we manage labral tears? This chart indicates the case for conservative management. Here is a case series of 4 patients conservatively managed with trunk stabilization, muscle strength, sensory motor training, and manual therapy. The next 2 slides provide a more comprehensive reference of a systematic, pragmatic approach. You may reference these slides in the future. We are gaining ground on managing patients with labral pathology. However, there are still questions left to be answered. One can question the superiority of manual therapy versus exercise, as well as looking down to the foot and ankle for a regional interdependence approach. This slide provides some food for thought. During a recent meeting with a team of hip surgeons, they presented these categories. They found that those who do best with surgery are male under the age of 30 with no signs of OA. Those that do worse are over 45, mostly female, and present with OA and a higher BMI. The gray zone is those in between with very mild symptoms of OA. So what does surgery entail? First, it is reserved for individuals who have positive MRA findings confirming a labral tear and persistent hip pain that is not responsive to conservative management. Surgery includes correction of bony abnormalities along with the repair of the labrum, and unfortunately results in a wide range of satisfaction. Prognostically, we see a wide range of success pending comorbidities and associated diagnoses. Post-op rehab is most successful when it is individualized, evidence-based, focused on circumduction, and special care is taken to avoid hip flexor tendinitis. This slide is a good algorithm breaking rehabilitation up into 4 categories, starting with maximum protection. The following slides will be provided for reference as patients may be referred after surgery with a unique set of instructions. Loosely, we see some initial weight-bearing and range precautions. In phase 1, we see gentle range of motion and isometrics. We then see progression to full range of motion and more neuromotor control exercises. In this protocol, and for most with hip pathology, we want to prioritize gluteals and can use these EMG findings to select those exercises with the highest EMG activity of the gluteals. In the later phases, we see the importance of testing patients' ability to resume prior levels of activities. Moving posteriorly, we will discuss hamstring tendinopathy, ischial bursitis, and piriformis syndrome. Intra-articularly, we will look at pain sources including posterior impingement.